Hey everyone, welcome back to NSG 3046 Adult Medical Surgical 2. Professor Murphy has invited us here today, and we're diving into something that touches every single patient you'll see: nutrition. Now, if you've been following along, you know we've talked a lot about neuro and stroke care lately, but honestly, nutrition is the backbone of recovery in just about every medical scenario. So, let's get into the basics first. What does a balanced diet actually look like for adults? Well, the USDA's MyPlate is a great visual. You want a mix of fruits, veggies, grains, protein, and dairy. But it's not just about the food groups, it's about the nutrients inside them. We're talking macronutrients like carbs, fats, and proteins, and then micronutrients, which are your vitamins and minerals. Water, too, can't forget that. Carbohydrates are your main energy source, and you want about 45 to 65% of your daily calories from them. That includes both simple sugars and complex carbs like whole grains and legumes. Fats get a bad rap, but you need them, just not too much. Aim for 20 to 35% of your calories from fat, and try to focus on the healthier ones like monounsaturated and polyunsaturated fats. Omega-3s are especially heart-healthy. Proteins are next. Think tissue repair, growth, and maintenance. You want 10 to 35% of your calories from protein. Animal sources like eggs, fish, and poultry are complete proteins, but plant sources like beans and nuts are great too, just sometimes incomplete, so variety is key. Now, vitamins and minerals. These are your micronutrients. Some dissolve in fat, like vitamins A, D, E, and K, and others in water, like vitamin C and the B vitamins. Minerals like calcium, iron, and magnesium are essential for everything from bone health to oxygen transport. And don't forget, special diets matter. Vegetarian and vegan patients need careful planning to avoid deficiencies, especially B12 and iron.
I always tell my students, don't just assume someone's diet is healthy because it's plant-based. You gotta ask questions. And then there's cultural and religious practices. Some folks avoid certain foods for faith reasons, so always check in and don't stereotype. Nutrition labels are your friend here. Teach patients how to read them. Look for serving size, percent daily value, and watch out for added sugars and saturated fats. Let me give you a real-world example. I had a patient, KL, who ate a lot of fast food, 3 meals a day, plus snacks like chips, grapes, and ice cream. My concern? Way too much saturated fat, probably over 35% of her calories. So what did we do? We talked about grocery shopping for easy, healthier options, swapping chips for popcorn, and trying fruit pops instead of ice cream. It's about small, realistic changes, not overhauling everything at once. Okay, so that's the foundation. But what happens when nutrition goes off track? Let's talk about malnutrition, because it's more common than you might think, especially in our hospitalized patients.
So, malnutrition isn't just about not eating enough. It's any deficit, excess, or imbalance in essential nutrients. That means you can have undernutrition, overnutrition, or even malnutrition related to chronic disease. For example, think about EP, an 84-year-old man I cared for who was being discharged after esophageal cancer treatment. He was also diagnosed with malnutrition. He lived with his wife, both in their 80s, and they didn't have family nearby. That's a classic setup for food insecurity. Maybe they're choosing between paying for heat or groceries, or they just can't get to the store. Socioeconomic factors play a huge role here. Older adults, people with chronic illnesses, or those struggling with substance use are all at higher risk. Sometimes it's not even about access. It's about knowledge or the ability to prepare food. So, how do we assess for malnutrition? Start with a good diet history. What are they actually eating? Then look at their BMI, but don't rely on it alone. Lab tests help too. Albumin and prealbumin levels can give you a sense of protein status, though they're not perfect. Electrolytes, CBC, and even vitamin levels can be useful. And don't forget the physical exam. Look for muscle wasting, edema, or changes in skin and hair. For interventions, you want to start simple. Daily calorie counts, high protein and high calorie foods, and small, frequent meals can make a big difference. Supplements are great, but only if the patient will actually take them. Sometimes you need to bring in a dietitian, especially if things aren't improving. And if oral intake just isn't cutting it, that's when we start thinking about more advanced nutrition support. But before we get there, I want to mention, malnutrition isn't always obvious. In developed countries, vitamin deficiencies are rare, but you'll see them in folks with alcohol use disorder, chronic illness, or really poor diets.
And don't forget about drug-nutrient interactions. Some meds can mess with absorption or metabolism of nutrients. So, you've done your assessment, you've tried the basics, but what if your patient still isn't meeting their needs? That's when we move into enteral and parenteral nutrition, which is a whole different ballgame.
All right, let's talk about what happens when eating by mouth just isn't possible or safe. Enteral nutrition, tube feeding, is your first line if the gut works but the patient can't eat enough. This could be due to anorexia, head and neck cancer, or even severe burns. You've got options: nasogastric tubes for short-term, or PEG and jejunostomy tubes for longer-term needs. Now, nursing care here is all about safety. Aspiration is a big risk, so always check tube placement. X-ray confirmation for new tubes, mark the exit site, and check before each feeding. Keep the head of the bed up, at least 30 to 45 degrees, and leave it up for a while after feeding. If your patient starts regurgitating formula, stop the feed, check placement, and assess for aspiration. Site care is another biggie. Assess the skin daily, keep the area clean, and watch for infection or irritation. And don't forget tube patency. Flush with water regularly, especially before and after meds or bolus feeds. I can't tell you how many times I've seen tubes clog because someone skipped a flush. Oh, and here's a safety story for you. One time, in a busy med-surg unit, a new nurse almost connected an enteral feeding tube to an IV line. That's a huge no-no and can be fatal. Always double-check your connections, label everything, and if you're not sure, ask for help. Now, if the gut isn't working, think bowel obstruction, severe GI disease, or after major surgery, then we go to parenteral nutrition, or TPN. This is nutrition delivered straight into the bloodstream, usually through a central line. It's customized for each patient and includes dextrose, amino acids, fats, electrolytes, and trace elements. TPN is life-saving, but it's not without risks. Refeeding syndrome is a big one. Watch for low phosphate, potassium, and magnesium, especially in patients who've been malnourished for a while. Other complications include hyperglycemia, liver dysfunction, and catheter-related problems like infection or air embolus. Nursing care for TPN is detail-oriented. Vitals every 4 to 8 hours, daily weights, frequent glucose checks, and strict monitoring of labs. Change the tubing every 24 hours and never let the bag run dry. If it does, hang D10 in water until you get a new bag. And always, always teach your patients and caregivers what to watch for at home. Nutrition support is a team effort, and as nurses, we're at the center of it. All right, that's a lot to take in, but these are the real-world skills you'll use on the floor. Thanks for listening, and keep those questions coming.